All right, hello everybody. Glad you're able to join us today. We are really excited to be talking about population health and how simulation can be used to look at population health and why that's important, how it can be done, and we're going to take a look at a couple case studies today. So really excited about today's conversation. I want to get started and introduce you to a few of the folks you're going to hear from today. We can. So there's going to be three folks on the conversation today. Myself, being the U.S. lead for healthcare with Simulate. We're also going to hear from Simone, who is the Director of Community Development and Integration at Mount Sinai in Toronto, and she is going to give us her perspective on how she's used simulation to model some of the population health questions that they're facing, that they're looking into. And then we're also going to hear from Claire, who's worked extensively with UK NHS. She was one of the original developers of Scenario Generator and has extensive experience looking at population health in the UK. So just a little housekeeping before we get started. So you can manage your own audio, as you can see on the screen there. And if you have any questions, please feel free to jump in. We'd like this to be an interactive conversation and to keep everybody engaged in the conversation. So if you have anything that you're interested in, please shoot us an email or send us a message through the chat function on the right hand of your screen. And then I'll jump in and ask our panelists those questions as they come through, and then we'll also save some time at the end for questions. Finally, the recording of this session will be available on simulatehealthcare.com, so if you need to jump out or there's something that you want to take a look at later and review, you'll find that there. I also do want to mention that we're going to have some polling questions, and so stay alert. Those are going to come up throughout the presentation. We want to get everybody's feedback and your thoughts on some of these scenarios. With that said, we're going to get started. So we've already done a little bit of our introductions, and we're going to talk about population health and about some of the trends that are happening in the area and some of the things that people are looking into. Kind of talk about the current state of how population health decisions are made and kind of where we'd like to see that go. Talk about the triple aim vision from IHI, the Institute for Healthcare Improvement, and how that fits into the population health movement that we're really starting to see. And then we're going to look at a couple of case studies, because that's really the best way to talk about it, right, is to actually see real examples. And then finally we'll wrap things up and open it up for questions. So I'm just going to give us a quick start on kind of what's happening in healthcare today. So as you know, there's a lot of changes that are happening in the industry, and these are just a few of the major ones from our perspective. First and foremost, the need to look at costs. We're all experiencing smaller budgets, tighter budgets, things that are really starting to constrain what we're able to do. We're seeing hiring freezes, we're seeing a lot of supply chain initiatives, IT initiatives trying to help people manage those costs of providing care. We're also globally experiencing an aging population, and so of course there's lots of downstream effects from that, including the chronic diseases that come with an aging population and kind of a different set of clinical needs that we're going to need to be able to plan for and address in the near future. In the US, we're also looking at a post-reform environment where there's a lot of puzzle pieces that are up in the air. There's a lot of change around payments and reimbursements. There's a lot of change around insurance and how all of the structures are set up, and that's continuing to change, and it's an evolving world. We'll talk about that in a little bit more detail in a little bit. We also have some new payer and commissioners who are changing the way healthcare is being delivered, and really setting some new standards and some new objectives for us. And then we have, of course, the evolving patient expectation, patient satisfaction, access to providers, the environments in which people want to receive care and their expectations around that is all changing and really impacting how we are going to deliver care in the future. So, with all of that said, what is our result is really that we're in an environment where population health management is not only greatly needed, but is really become a key focus area for many organizations as they see that the needs of their population are changing and their role in providing that care is also evolving. In that context, I think it's important to take a step back and say, what do we really mean by that anyway? So population health is becoming more important, and everybody is coming to consensus with that, but the question is, what does that really mean? And of course, everyone has their own perspective. These are just two definitions that we pulled out, but I think they're representative of some of the varying perspectives. So the first definition there is from Health Finance News, obviously a financial organization, and they really tend to advocate for, yes, it's about the clinical side of delivering care, but it's also about identifying the gaps, addressing them in lower cost environments, right? If we can catch things earlier, if we can do more interventions earlier, if we can do more prevention, we can save cost in the long run. And they're really looking at it from a perspective of that financial need, and also really emphasizing that we need a lot of data in order to be able to manage the population. On the other side is another quote there that you see, and that perspective is much more focused on the clinical outcomes as opposed to the financial implications. And so this particular perspective is really much more focused on, yes, it's about the health delivery system, but it's also about public health or agencies. It's also about the community-based organizations. It's also about the social and the environmental factors and all of the other stuff that goes into determining kind of the population health state of a group of people, of a community. So just kind of interesting to see that contrast and people's different perspectives. From our perspective, we think IHI's triple aim statement is probably the best all-encompassing vision of where population health needs to go and how it fits in with the broader vision for healthcare. And so this is their definition of what the triple aim is. And you see there that the health of the population is one piece of it, but also the experience and the outcomes, and then also that financial capital cost piece. So they're actually kind of separating population health from the financial needs of a population. And so it's kind of two separate areas, and then we would agree that those tend to be sometimes different topic areas, though obviously tightly integrated. All of that comes together, I think, in that we really are in an environment where we need to understand our population. We've got to do better planning. We've got to understand capacity and utilization and all of the different factors that go into being able to serve a population so that we can deliver that care in the most effective way possible and get the most from it. So, I think it's important to put this all in context. And so that's kind of what we've just talked about. But then let's take it down a level and really think about what is it that we're trying to get done tomorrow, right? That all sounds good. Population health is important, but what do we do tomorrow? Where do we start? And I really think we need to deepen our understanding of each of the individual pieces, and then we need to figure out how do they fit together, because we can't look at all of these things that are happening, right, and actually address each one in a silo. We can't address each one individually because there's not enough time, there's not enough resources to do all of this at the same time if we don't think about it as an integrated package, right? And so you can see just a few of the things that healthcare organizations are facing. We're seeing the increase in chronic disease, which is tied into the aging population, primary care access in the U.S. especially is becoming more and more of an issue. We have expanded insurance coverage. We have new healthcare delivery structures in the accountable care organization and the patient-centered medical home, which is kind of a new approach to providing healthcare. In the UK, we have programs like 7-Day Working, which is really reevaluating the way we deliver care and the assumptions that we've had that are built into our current system. And so with all of these moving pieces, we've got to think about how do they fit together, and where do we start with all of these different initiatives that are happening, and then many priorities. One of the things that I think is part of the answer to that, right? Where do we start? What do we do? Is to really look for those areas of interaction, right? And it's very complex, but we can do it. And if you look, this is just one example, but I think it's probably the most powerful example of those things that we just looked at. If you look at chronic disease, if you look at the aging population, if you look at in the U.S. Expanded Medicaid coverage, newly insured patients, all three of those are to some extent looking at similar populations. They often have similar effects on the patient need and often compounding effects. So for example, as I age, not only do I have different needs, but I also have additional chronic diseases. I also have different insurance coverage as I move through different programs, different insurance structures. And so all of these pieces are fitting together and compounding each other to create more complex demographics and needs from the patient perspective. And then most importantly, if I look at, for example, these three, while they're all independent drivers of things that are happening, really the solutions, the things that we're going to need to do to address the needs of increasing chronic disease, the things that we're going to need to do to address the aging population, they're often overlapping solutions, right? And we can hit multiple areas at the same time if we plan it well and we structure it well. And so really looking at it from this combined perspective, there's just a few examples there on the right of some of the things that we're going to need to look at, right? The increasing patient acuity due to all three of these factors, the disease interactions that are going to happen with all three of these, the importance, and I think this is probably one of the most interesting, the importance of the environmental, social, community factors that really affect the health outcomes of patients. And so if we can look at how these different pieces fit together, we can be much more effective in making those policy decisions and those operational decisions about where we're going to focus time and effort. So when we look at what are the interventions that we're going to do to address some of these drivers of change in healthcare these days, any population health strategy really needs to address a couple of questions, right? Regardless of what the strategy is, or regardless of what the issue is that we're trying to look at, we have to answer these questions first. So first and foremost, what is the capacity we're going to need? How is the capacity of physicians going to change? How many nurses are we going to need? What are the demographic factors in some of those populations that are going to affect their availability? For example, in the U.S., often our primary care physicians tend to be in the 45 to 55 range. Many of them are starting to think about retirement. How is that going to affect the capacity we have? How is that going to affect the capacity that we need? And what is the resulting utilization? And one step further, what effect is that going to have on lead times for patients to be able to get in? What effect is that going to have on wait lists? What effect is it going to have on patient access to appointments when they need them? Of course, secondary to that is how much is it going to cost? And can we better manage that capacity to reduce costs? Can we change the way we're using that capacity to reduce costs? And then how do all of these things affect clinical outcomes? At a minimum, we need to maintain clinical outcomes. In an ideal world, we would improve utilization, reduce cost, and improve clinical outcomes, right? How do all these pieces fit together? So historically, we've had a strategy for looking at, if we can just slip to the next slide. Historically, we've looked at this kind of process for making these decisions about which initiatives are we going to pursue first, how do we prioritize all the work that we have to do, and what initiatives are going to be the most effective. So this is just an example, but many organizations go through a similar type of process. So we're often starting out with some sort of data gathering phase, right? We call our strategic planning department. We call some of the public health governmental organizations, all sorts of different folks that we can call for data, and we do a bunch of gathering, but often it's not the data we were looking for, or there are some flaws in it, or it's a partial data set for whatever reason. So we're doing all that gathering up front, but we're not necessarily able to fully capitalize on it. The second phase then, once we've got all that information, is to look at it and say, okay, so let's gather a team and let's brainstorm a long list of potential changes that we could make, right? We can move this patient population and have them see a nurse practitioner instead of physician. We could do additional education. We could hire some more staff. We could change the clinical protocol. All sorts of ideas, right? All of which are valid and good ideas for things that we could do to improve population health. But this is my slightly cynical comment, but I think often organizations will bring together experts and will come up with a list of potential changes, and then when it comes down to the idea selection, right, which of these ideas are we going to do today, where are we going to start? It's often, those ideas are often selected based on criteria that maybe are not as evidence-based as we would like, right? Who has the most seniority, who has the most experience, who has the right political capital, and so often those decisions of where to start are not necessarily made based on as much data and evidence as we would like. Once we've picked a few ideas to focus on, then we go and often, at least in my experience, the solution that we pick to look at is request more staff, right? More staff will fix the problem. So we write the business case, we submit a request for more staff, and of course there's not money in the budget, and so we go back through this process again, right? And we cycle through this until eventually we find something that we can argue for and that we can rationalize, and we end up implementing that change. We pick something we think will work, we make the change, we call it a win, right? Lots of challenges with this, lots of potential opportunities for a better way to do this. So we can just flip to the next slide. Talk briefly about one way that we might do it in maybe a more effective methodology for picking interventions to focus on and changes to make. So if we think about the scientific method, what is it really designed to do, right? It's designed to make sure that we make evidence-based decisions, that we're making decisions based on data and actual experimentation. It's intended to help us achieve predictable results, right? So we know what's going to happen every time we do something, as opposed to hoping for the best or kind of some of the other things that we do today. And it's also intended to help us make targeted changes, right? If we use a methodology like the one on the left, we cycle through this. This is a continuous improvement process, right? It's not a one-time thing and then we've solved population health. But we continue to go through this process over and over again. We're going to start to be able to target those changes that we're making to be the most effective at the lowest cost possible. So if we can just flip. Sorry, we seem to be having a little bit of a technical challenge. We'll be there in just a minute.
There's a bit of a delay. Sorry. There we go.
No problem. Thanks, Claire. So what does that mean? What it really comes down to from our perspective is that we need some new strategies because all of the tools that we have in our toolbox today, right? The Lean and Six Sigma from a process improvement perspective. Public health has some great tools. Epidemiology is critical to this conversation. And all of these are really important to addressing population health, but none of them are fully equipped to look at the whole system, right? And look at how demand and costs, quality, clinical and non-clinical, how all of these pieces fit together. And so the argument that we would make is that really it's time to bring these groups together, right, to help them cross some of those boundaries and break through some of the silos that exist today, and then also to give folks a new type of tool, and this is where we believe simulation fits in that simulation can help all of these folks sit together, brainstorm that list of possible solutions, and work together to figure out what's going to be the best solution. Sorry. So what I want to do now with that kind of perspective in place, and hopefully if you have any questions about that or anybody has some thoughts, please feel free to jump into the chat window and send us a message, and we'd love to have your thoughts on that that context, because there's a lot of stuff that we didn't get into yet. And I'm going to hand it over to Claire, and she's going to talk through some of the simulation perspective and then walk us through a few case studies.
Thanks very much, Brittany, and hello everybody. And I just want to say that it's been fascinating having the discussions to prepare for this seminar, because we're privileged, I think, to be able to work across Canada, the US and the UK, and with these complex issues around population health. It's fascinating to hear the different perspectives based on our different service methodologies, on our different cultures, but how actually there's an awful lot of common ground, discussing how we might use simulation to help people think about population health and how it affects service utilization. We found all sorts of ways in which we can really work effectively together, and that's really some of what we want to talk about today. So we've been using simulation to think about these questions. We've been building in demographic data to our models so that we're powering them with the populations or the communities that health services are serving, to understand what that might mean for demand. And then we're testing scenarios that enable us to understand what might be the impact of that changing demographic on our existing service, how if we change the configuration of our services or the flow of patients around the system, what that might mean. And the benefit, of course, as always with simulation, is that it's not costing us anything, we're not going to hurt any patients, and we can look and see what might happen, particularly in these complex areas where we're crossing organisational boundaries before we bring in a change. So a number of online experienced in simulation, so apologies just for picking up this slide, and you may have seen it before, but just to remind people who are not familiar what simulation is, what we're doing is modelling a flow of patients. And you can use that at any level really, but today we're interested in how that affects a whole system. And so we're modelling the way in which they arrive into the system, how long their treatment lasts, where they go next, how long that takes, what our capacity is, and what that might mean for waiting times, bottlenecks within them. So we're modelling the passing of time, and our experiments are being conducted at quite a high level. What if we bring in a change in 1 year? What does that mean in that year? What does that mean in the next year, as our population changes? And then what are the annualised costs and resources and waiting time? So quite a high level discussion about those sorts of questions today. Now, before we get on to some of the specific case studies, I thought it might be useful just to play through this dementia care model, which I think picks up and illustrates quite nicely the sorts of things that Brittany has been talking about. And as I run that through, what we're doing is we're running people with dementia through a disease model, and it's then populating a service model, and we're running it over a number of years. So the basis of this model is a population, and we're expecting that that population, a proportion of that population will have mild dementia, which will move to moderate dementia and severe dementia. And it depends on the whether you're diagnosed or not, and so we've got an undiagnosed path and a diagnosed path, because not everybody's diagnosed, as to whether you get services or not, and obviously you have different sorts of services depending on the disease state that you're in. So this is what the model is dealing with, and I'll just run that excuse me, to the end so we can get the final results. And what we're looking at here, and this is a UK model, is being able to put the population that you like into the model, so that we don't have to repeat this several times, and you can just add in. We've based this on data that's been published, and you can also edit the number of people that are diagnosed. And one of the questions that people have often wanted to ask about dementia care is what happens if we diagnose people at an earlier stage of dementia and we start treating them. It's going to cost more. It's maybe going to be a difficult thing for the families and the people themselves to reconcile. But actually, if that means that they stay at a mild and a moderate phase of the disease and perhaps die of something else before they get severely, they have severe dementia and require a number of different quite high-level services, and also lose the independence that they might have had, is that possibly a better thing to do? So you can edit the number of people you think might be undiagnosed in your area, and you can also edit the services and how much they cost. So we made this localizable. Now, one of the interesting things, I think, is looking at, when we were developing this model, we were looking at the ways in which we ought to understand the population health of people with dementia. So we know that there are a number of different dementia type conditions, and we know that they affect men and women differently, and that also they progress differently. So and there are different levels of severity. So we can have people with mild, moderate and severe dementia when they start off, and then that progresses over time. So you can progress from mild to moderate and from moderate to severe. So you will stay in those disease states, if you like, for that period of time, and whilst you're there you'll receive the services that are relevant to your particular stage of dementia. We're looking at incidence and prevalence here of dementia, and again this is all from nationally published data, and we're also looking at current diagnosis. So we've got a lot of different data which is in the model, which enables us to really relate the population health, the disease model for people with dementia, which will be different depending on how many over 75s there are in our individual population, and understand the impact over years of that particular demand. And you can see here the kind of results we can get, so we can see how many people are in that kind of state, and also have a look at our costs. So that's just a quick live run, and I can compare my different scenarios to see, well, if I diagnose more people or less people, what's the difference in costs there. And that enables me just to think through what the overall impact might be. So let's just make that change. And run it through again. So I just wanted to show you that really as a kind of live example of a population health driven model, which a number of you will be used to seeing and to using, and to understanding what that might mean. Now, of course, these services will be in primary care, they'll be in community services, they'll be in social services, and they'll be in hospital services. So everybody in a health service, in a health system, will be meeting the needs of people with dementia. But obviously the burden of the cost is going to fall differently, the revenue is going to fall differently, and what we really want to do is to get the best outcome for this group of people. So I can now look at my different results and I can see that I get a slightly different number of people. So I've got more people that are diagnosed now with dementia as a result of running my scenario. And if I look at my costs, you can see that there's a difference in cost. And in actual fact, over time, it might cost me slightly less because people don't move into that severe form of dementia. So all the time, what I'm taking into account is the impact at the severe end. So you can see here how the costs differ at that severe dementia stage and how they differ at that early diagnosis stage.
So Claire, if I can just jump in real quick. I think this is a really interesting example because oftentimes when we talk about population health, we're talking about prevention, right? Prevention, early diagnosis, and we all believe that it's going to be a good thing for the patient and a good thing for cost. But can you talk a little bit about using this as kind of almost a negotiation tool or a budgeting tool for how do I actually quantify and how do I get other people on board for, you know, we need to make this investment up front because actually there is a real cost benefit and a clinical benefit, kind of
yeah, no, thanks, Brittany. Those really interesting questions. I think when I first started doing this piece of work, what people were doing was to say, right, we've got this number of people with dementia based on our known prevalence, and looking at our incidence data and looking at our population, we expect to have this greater number of people with dementia in 5 years' time. But what struck me was that that was a very simplistic way of looking at things because, of course, the stages of dementia are really important. And so if you were to project the same level of services for people with dementia without taking into account that progression, and if you could do something about that progression, you would change the pattern of services that people would need. Now, of course, the big issue here is, well, if I'm running a memory assessment clinic and everyone starts diagnosing more patients, that means I'm going to have to have a lot more capacity for memory assessment clinics than I used to. And how much does that mean? Does the revenue it provides enable me to run it sufficiently? And what does that mean, therefore, for my care home allocation and how many places I might need to project into my care homes, and the market is interested in knowing that. So as the system works together to understand what it means to care for people with dementia and to put in place best practice care pathway, of course there will be financial winners and losers perhaps within the individual organisations. But so somehow we need to make sure people are sufficiently incentivised to provide the best practice care, get sufficient reimbursement to feel that it's worth their while doing that, and the best outcomes for patients. Now, none of that is a simple thing to negotiate, but at least by having a clinically correct model which allows you to understand what the demand might look like and what the impact might be if you change the way in which people traditionally access those services, and look at the financial flows, means that you can have a negotiation around that. And there are trade-offs, and there have been trade-offs between different organisations to manage that really in the best interest of the patient. Does that answer your question?
Yeah, it does, and I think it's really helpful to hear your perspective on it. In the U.S., we're finding that increasingly in the last maybe 5, maybe 10 years, a lot of systems are integrating, right? They're going from being standalone hospitals to being hospitals as part of a network that also have long-term care, that also have rehab, that also have psychological services, and they're really expanding into health systems as opposed to standalone units. And so actually what we're seeing is exactly that dynamic that you're talking about, where there's some winners, some losers, if we look at individual budgets, but as a whole we can actually do a better job of planning and managing that. So that's really exciting to hear about. Thanks.
No, great. That's interesting to hear your perspective as well. So what I wanted to come on to next then was to talk about a tool we've been using called Scenario Generator, which was developed in the NHS in the UK and was deliberately built for strategic planning for health and in fact social services, so that you could pick up any number of conditions or multiple conditions from your population and disease prevalence. So we've uploaded that data ready for people to use, and then look at a whole disease pathway which takes into account all sorts of different organisations, but is really developed from the perspective of the patient. How many people in the population that you serve as a system are likely to become ill with this particular condition, what the typical flow through services is, and that could be different if you're insured to if you're uninsured. So behaviours also form a large part of why it works in that particular way, and what might happen if you made a change to any part of that pathway. So what's the downstream effect? So you might make a change in primary care, for example. What's the knock-on effect there to hospital services and then to any discharge services later on? Now, it's interesting, this tool. I developed it with a number of colleagues when I was in the NHS to apply to some of the strategic questions that we've had, but it's interesting that it's been used in a number of different countries, and we're going to come on to an example in Canada, but we've just learned that the Australian government is looking at using it now for their submissions to their pharmaceutical advisory board. So there are all sorts of different uses for it now, and what it's doing is looking at your population, how those demographic projections and age-related factors that influence demand might impact on your activity, and simulating those patient journeys through the services depending on the needs of those patients. And the idea is that you configure it to look at some of your what-if questions. So in a minute, when we've accounted for the time lag, you'll see the scenario generator functional map, which just explains that a little better. So we've got a population and prevalence influencing factors on the left-hand side, moving into a set of pathways which are preloaded, and you can break down into as many pathways as you like. And each of those pathways is made up of a set of services which represent the flow across the whole system. And you validate that, so you're seeing the sort of results you'd expect to see in each organisation for that group of patients. And then you can say, well, what happens if we run that forward for 5 years, just looking at the increase in population? What happens if we change the flow around the system? What happens if we run out of capacity, as Brittany was saying, because our workforce is ageing, and how can we manage that? So some of the things that you can see that being used for is chronic condition management, population health needs assessments, health disparities, health inequalities as we call them in the UK, how services can be integrated between health services and with social services, looking at the coordination of care after people have been discharged from hospital, and also shifting the traditional care that's been traditionally been managed within an acute setting to something to a low acuity. So I'm going to come on now to share with you a case study around modelling maternity with Mount Sinai. And Simone, are you there? I'm just going to invite Simone to join the discussion now. Hello. Hi, Simone. Can you unmute yourself? I think you might be muted.
I definitely was muted. Sorry, Claire. Thank you.
That's okay. Lovely to hear you. Thank you so much for joining us.
Thank you. Hello. Hello, everyone. So just a little bit about Mount Sinai Hospital.
Please, thanks.
Which is a hospital, acute care academic teaching hospital in Toronto. Of course, Toronto is a large urban center, and so we have quite a diverse demographic that we work with. One of the specialty areas at Mount Sinai is working in women and infants health care, and specifically we are the high-risk facility for the province of Ontario, so we see large numbers of women who are coming in as a result of pregnancy and dealing with complications related to delivery. So
thanks, Simone. Yeah. Go on. So what we were doing, I think, was creating a. I think we worked with you and helped you to create a model that looked at what you might expect for maternities in Mount Sinai and how that might impact on your capacity. And on the slide at the moment, we've got the population of the Toronto Central LHIN, and we looked at the conception rate by female age band, which gave us an annual number of births, and then we split that for what we expected to be the uninsured group, and also looked at how the population was changing, and with those fertility rates, what that might mean for increased numbers of births over time. And I think, could you just say about your interest in modelling the uninsured versus the insured women in your pathway?
Yes, so specifically we know that in the Greater Toronto area there are communities of people who are residing in Toronto but do not have healthcare coverage. Therefore, they don't carry the Ontario Health Card as many people in the population do, and their access to services is quite dramatically affected by the fact they do not have the Ontario Health Card. And so based on some high-level data in the Women and Infants Health Program, we did understand that we were seeing large numbers of women without this provincial or federal health insurance. And so we were trying to work through the problem of how to provide services for those women, because most of the time the place where they would access services was when there was a major healthcare issue or healthcare problem, and so we would see them coming through the emergency room as the primary pathway into the system. We wanted to figure out strategies to intervene in a more proactive way in terms of really engaging with this population, so they would come in for things like prenatal care, and so they would come in for monitoring of the pregnancy as opposed to waiting until the late stages of pregnancy when there was a problem. And as we all know, accessing the system at the later stage of a illness or disease is probably the most costly point of accessing services. And so we were trying to work with this population to figure out how they could be seen in a more proactive manner. So the idea was that we were trying to propose starting up a prenatal clinic for women without health insurance. And so the challenge was to come up with the evidence to support that initiative. And so working with a colleague of mine, Dr. Eileen Pepler, who introduced us to Simulate, was a really great opportunity for us to begin to build a business case to have this particular clinic as part of the complement of services at the hospital.
And I thought what was so interesting, Simone, about the work and about the mapping you did was the significant difference for, as you say, for women who are uninsured, who are coming in at late stages and much, much more likely to be an inpatient at that stage for a long time, a long period of time before the birth, or coming in and out of hospital for many more stays than those women who had had all of their antenatal care with you.
Yes, absolutely. And also to add to that, the number of complicated births was also an interesting finding as we ran the simulation. So when we looked at the data, we did identify that given the women are coming in late stages and tend to have more complications, that there were higher numbers of cesarean sections, which of course impact the length of stay in hospital. And then related to that, the newborns had also clinical complications, which was another component of this which we needed to address.
I think one of the things that we were looking at was what's a reasonable bed capacity for, if you understand the complex nature of that group against the more routine care that people were getting, and also took into account the increasing population, female population. What sort of numbers of beds should you be planning for to always make sure that there was a bed available when you need it? And you can see on the screen here that when we took a number of 180, you can see there's always a maximum of 119 in use. So we had a sort of 48% utilization rate in that particular scenario. So you wouldn't need the 180, but you would probably expect to have a number of beds underutilized in order to make sure that there were no waiting times for a bed when people need it. And that was, I think, an interesting discussion that triggered about bed management. Isn't that right, Simone?
Yes, absolutely. So we had a lot of discussion around just the number of beds, as you say, Claire, that would be required, and then how to obviously make sure that the bed spacing was adequate to provide for women coming in on an emergency basis.
Yeah. And we ran a number of scenarios to say, well, if you're not, you can see the difference if you're uninsured versus if you're insured. On your utilization and how much that would cost. So we ran a range of scenarios around that, and also had a look at what would happen if there were 5% fewer elective C-sections. I think that was one of the things you were hoping to reduce your numbers of elective C-sections, and wanted to understand the impact on that.
Yes, that was a very important piece of this work that we were doing, just in terms of really trying to, again, figure out ways that we could prevent the rising number of C-sections by hopefully providing services at the front end, so those prenatal, antenatal services that are so critical during pregnancy in order to ensure better outcomes for the women and the infants.
So, I mean, we did that, I suppose, a little while ago, and I know there was a lot of conversations about it. Just reflecting back on that and knowing what you now know, Simone, what are your thoughts?
Well, I think this was probably the only tool available to us in order to build a case for having these type of prenatal services for this very vulnerable population. And I have to say, without it, I don't think we would have come this far along in the process in terms of having the evidence to really produce for the senior leadership in the hospital to think critically about the need for the services. So it's not intuitively, it's not based on our intuitive, understanding that we need the services, but now really grounded in some concrete evidence, and having had the opportunity to run the scenarios and be part of that process, I think that without it we would not have been at this point. And the point that we're at right now is that we have several partners who are interested in working with us on this clinic. We're moving towards implementation, and to our great delight and surprise, very recently we've been able to attract a private donor who is very interested in also helping to support us by providing funds and resources to start up the clinic. So there's been a lot of good news as a result of this particular example of using scenario generator, and we're very, very pleased with the outcome and the many benefits to come in the very near future.
Oh, that's fantastic to hear, Simone. I'm so glad that who would have thought when we were sitting in the freezing cold doing this modelling that that's where it would have ended up.
Yes.
I'm just going to quickly go through the another example, which was also a very interesting example. And what was I was in Toronto working with you on the maternity model, and I think one of your stakeholders came in and said, well, what about the food bank?
Yes.
And so I think we just sat down and did this piece of work, didn't we, just one afternoon.
Yes, another exciting project.
And as I recall, what happened was that the question was, you had people coming into the food banks, they clearly had health needs, they weren't being met, and the food banks were thinking about employing a nurse to see some of the people in the food bank, and understanding that that might stop some of the attendances at the emergency department. So we built a model that was based on the number of visits to the food bank, and expecting that some people wouldn't consent to be seen by the nurse, but some of them would, but if they had to wait too long, they would probably go to the emergency department, and that's our little route out here to the emergency department. And we were modelling the capacity that a nurse, the first nurse appointment and nurse follow-ups might need to be in order to meet the needs of the people visiting the food bank. So you can see there the number of nurses, how many visits a year, the cost that we put in, and how long we thought people's threshold of waiting would be before they would take themselves to the emergency department. And we tested this through with the stakeholders, ran it through, and looked at some of the results, and you can see those on the screen there. What we found was that actually adding a second nurse in fact reduced the overall cost, because if you took into account the cost of the emergency department, it was certainly worth funding 2 nurses to meet that demand. And I wondered how whether that had been useful to the Toronto Food Bank, Simone.
Oh, it's been incredibly useful to the food banks, to our Toronto Local Health Integration Network as well, because the LHINs were particularly interested in the outcome of this scenario, because what it means for them, it addresses a major priority around making sure that people who are not attached to primary care, such as food bank users, are now linked in to receiving primary care services. So this has had a lot of really, really interesting results in terms of just conversation around how useful this is to be able to identify some of those population who are vulnerable and who are attending services, social care services that may not be directly linked to health services yet, but just how important it is to integrate those 2 services, health and social care, in order to effectively meet the needs of the population. So a lot of interest here from our funder, which is exciting.
Oh, that's good to know. And I think that you've gone on to do some modelling for the refugee population and health links overall. Is that right?
Yes, so we have 2 other projects underway, which is also generating a lot of discussion and exciting. And we've just run those scenarios and are now in the process of validating them with some of our colleagues and subject matter experts in the sector. So we are looking forward to the outcome of those conversations as well. And it's just incredible how we've had a lot of opportunity to use this tool, but each time we've used it has resulted in success in terms of just having, you know, the right players at the table, having conversations around how we could continue to provide, you know, effective and quality services while achieving efficiencies. And so very, very interesting conversations about how we move forward, not just as a hospital, but as part of the health system as well.
That's great to hear. Thank you so much, Simone, for being able to share that with us. And I think it's my experience as well, actually, that sometimes it's the conversations that this provokes and the discussion that it provokes between the different partners, which helps to move the change forward in a way that just sitting around the table and discussing it without this kind of evidence doesn't really do.
No, absolutely. And the other thing for me is that the population is constantly changing, so it's dynamic. And so this tool allows you to, you know, enter in those demographic changes or changes to disease prevalence as they're happening. And then you can also look at different scenarios around, you know, how you would proceed in terms of providing services to communities of people, new communities coming in, or communities of people who don't have access to healthcare in the same way. So it's been very good results for us.
That's great, Simone. Thank you so much. We had a couple of other case studies, but which we wanted to send through to you in the slides. So when the slides appear, there'll be some further case studies that you can have a look through. And I hope you'll find those useful. But I think in the interests of time, what we'll do now is just to skip to the end of the presentation, because we're coming to the end of the hour. And I'm just going to hand back to Brittany just to wrap up for us. Hi, Brittany, you there?
And Simone, thank you so much for joining us. Yes, can you hear me?
Yes, we can hear you. Thanks.
So Simone, thank you so much for joining us today. I think your insight into some of the different ways you're using the tool is incredibly useful. I never would have stopped to think about the food bank as a healthcare provider until we started talking about some of these cases that you were going to share today. So that was immensely useful. And I think really interesting to hear about some of the unique ways that people are starting to think about population health and meeting the needs of underserved populations, which is obviously on everybody's mind and very important. So really quick, I just want to hit a couple of key points. I think we've talked today a lot about planning services around population health and how important it is in today's environment. And that really there are limited tools, and that the Lean and Six Sigma, epidemiology, public health, all of these are incredibly important to the conversation and key stakeholders as part of making population health decisions and figuring out where we can intervene to have the biggest impact. But that we really, as Simone pointed out, we need a tool to bring everybody together and provide that evidence. And as I think she said, root us in some actual data. The other thing that, of course, population health tools such as scenario generator, enable us to look at reducing the risk of our investments and really making those decisions based on evidence and looking at the clinical outcomes and everything else along with that. So we did have a couple questions come in, but out of respect for time, I want to make sure we get out on time. So we'll post those on the LinkedIn forum and answer them there. So if you have any questions, feel free to join us there and ask them there as well. And we'll have those questions there if you want to take a look at those. And then just wanted to mention that, of course, we're always continuing to look for interesting webinar topics. We really want to make sure that this is immensely useful to you as the attendees. So if you have any topics that you think would be really interesting, or you have a case study that you'd like to look at or share with the group, we'd love to have you share that information. So please feel free to reach out to me. You can see my email address there, brittany.h@simulate.com, and we'll continue the conversation online as well. So thanks, everybody, and we will look forward to seeing you next month.
Bye. Thank you.